So I've been in practice for just over 25 years now, and over that time, there's been a tremendous amount of change in spine surgery. Some of it has been technology that allows us to perform a given operation more safely and through smaller incisions. That's included increased use of microscopes, endoscopes, navigation, which are radiology-based techniques to allow us to guide our way through the spine without opening it fully up. Other things have been newer approaches. Things like motion preservation and disc replacement allow us to provide stabilization when it's needed without necessarily performing a fusion, which would cost motion at a given level. With any operation, you want to achieve a lasting response or result for the patient. You want to decrease their pain, improve their function, but you want to do so by affecting the normal tissues around whatever the disease process is as little as possible. The spine is actually pretty deep in the body, and what that's meant historically is you'd have to make fairly big incisions, move normal muscles out of the way to get at a disc herniation or whatever the other pathology might be. Smaller incisions and minimally invasive techniques have allowed us to successfully treat the problem without as much surgery, moving the muscle, or other tissue disruption. For patients, that means much less pain after surgery, it means a faster recovery, and probably lower risks. As a spine surgeon, we see a number of problems that need urgent care, fractures, certain tumors, infections, but the majority of spine problems are degenerative problems, things like disc herniations and bone spurs. Many of those patients can be successfully managed non-operatively, and our practice has a number of non-operative spine specialists that can address the pain and get people back to function. There are certain circumstances, though, where delaying care is actually not in a patient's best interest. For example, if the disc herniation or bone spur is causing not only sciatica type pain, but also weakness, it's important to get that nerve decompressed so the weakness doesn't become permanent. Problems that lead to marked difficulty walking, problems that lead to changes in bowel and bladder control, these are other symptoms that need urgent management surgically. Over the last 10 years and over my career in the last 25, I've seen significant advances in how we manage patients. I think they've come in a couple different areas. And one, we've understood some of the disease states better, including even relatively straightforward problems like spinal arthritis. That's allowed us to, when surgery is necessary, perform surgeries that are more durable over time and less likely to require patients to come back for additional care. But within those surgeries, we also have a much better ability to approach these problems with smaller incisions, with more aggressive rehabilitation techniques that allow patients to get back to life much more quickly. And so the net cost of the patient in terms of time away from their activities and return to a good quality of life is less. There are still conditions that require bigger surgeries and longer hospital stays, but for many of the most common problems, disc herniations in the neck or low back, surgeries can often be done on an outpatient basis or occasionally with a one-night stay. That not only allows patients to get back to life more quickly, but also reduces some of the problems associated with being in the hospital. There are a number of things we do in surgery today that have decreased our reliance on blood products for spine operations. One is smaller incisions, less invasive surgeries, which expose the patient to much less blood loss with a given surgery. On top of that, we have things that we do at surgery, including medications that can be given to decrease blood loss. And for those bigger surgeries, we use devices like a cell saver that will actually retain the patient's blood, clean it, and give it back to them. So the number of our patients requiring blood transfusions is far, far fewer and overall the minority compared to in the past. So a cell saver is a device that when you're operating, the cell saver will collect any lost blood, and that blood is then cleaned and returned to the patient immediately, which reduces their overall blood loss during a surgery and significantly decreases the chance they might need a blood transfusion. As someone who's been involved in spine research my whole career and has published numbers of papers in a number of areas, what we've come to learn is that there are patients for whom a spinal fusion is necessary. They have significant instability in their spine. But we've also learned that a lot of patients we used to think had to be fused actually can be managed with operations short of fusion. Those can include operations where we're simply decompressing the nerves without fusing or reconstructing the spine with a disc replacement. The disc replacement allows the patient ongoing motion at that segment and provides stability, restores height if the spine's been collapsed there, but doesn't cost them that motion, nor does it require screws, rods, and some of the constructs we've used in the past. When someone's looking for a spine surgeon, I think there's a few critical things to look for. First, you want to find someone who has a lot of experience with the kind of problem that you're experiencing. There are problems that every spine surgeon treats frequently, disc herniations being an example of that. And when you have a common problem, you want to find someone that has a wide range of treatments to offer for that problem. Ultimately, how far most people should go with a given spine problem has partly to do with what their MRI shows, but actually more importantly, it's how is that pain affecting their life? To what degree are their functions limited? So how we approach, let's say, a 25-year-old and how we might approach a 75-year-old are very different. And so if you have a surgeon that has I've got a hammer and the world looks like a nail and does everything the same way every time, that's really not in your best interests. In our practice, we have a variety of spine providers, both surgical and non-surgical, and we try to optimize your care based on what your functional needs are. And that can include non-operative care for the appropriate patient, which is all told 80 or 90% of people. But when surgery is recommended, in our practice, we tend to select the surgeon who has a lot of experience with a given type of surgery. Frankly, we're all best at what we do a lot of. And so when you're looking for a surgeon, you want someone that has a lot of experience with that procedure. In repetition, you get better and better and better. That decreases the risk and increases the recovery time for the patient. When patients come to me, I always appreciate good questions. I have a certain speech that I feel like I'm obliged to give, but I don't really want to bore the patient. I want to make sure the patient gets the questions that brought them in to see me answered. And different people have different things that are more or less important to them. For some, it's how their spine problem relates to their sports activities. For others, it's how it impacts their work life or family life. I think the more people have thought about their symptoms and their impact on function, on pain, on activity, the better I can address the role of different kinds of treatments in addressing those symptoms. The reality is a good surgeon is the one that spends the time communicating with you as to what your options are and how to think through those options to make the choice that's really the best for you over the long term. So in our practice, we have an almost equal number of surgeons and non-surgical spine specialists. Our non-surgical spine specialists will manage most spine problems with modalities like medications management, physical therapy, and injections. And if you look at the numbers, 80 to 90% of people can effectively be treated non-operatively. That's especially true for problems that haven't been there that long, especially under 6 weeks. Surgery tends to be reserved for patients with more chronic symptoms or symptoms that have failed to improve with appropriate non-operative care. But for the average patient that doesn't have significant weakness or limitations in function, non-operative evaluation and management is almost always a good idea before surgical consultation. How far someone should travel to see a spine specialist has to do with a number of different factors, but ultimately, those patients that have more unusual spine conditions may find it useful to travel. In particular, if you have a disc herniation and you have a local pain management doctor and they want to start with some physical therapy and injections, that's not an unreasonable approach. On the other hand, in our practice, we see a number of patients with very complex spinal problems. I, for example, take care of patients with complex cervical spine or neck issues. Sometimes those have been previous surgeries or fractures or deformities. There are not really that many spine surgeons that specialize in that area. And in any kind of spine care, you really want to see someone that has experience with your particular problem. Ultimately, the less common your problem is, or the less available a given treatment modality is, the more you ought to be willing to consider travel. I've been here at Texas Spine Scoliosis for the last 15 years. I'd been in practice for 10 years elsewhere, and I've really seen the benefits of our practice model. We have neurosurgical spine surgeons and orthopedic spine surgeons here. We have a number of non-operative spine specialists. What that means is when patients come in, they get care that's individualized to their needs. They don't get a surgery because I like to do a given surgery. They get the care that's really more appropriate for them, and it's non-operative care in the majority of cases. When a patient does require surgery, If it's a common surgery, any of the surgeons might be doing that surgery. But for patients with more specialized problems, each of us as a surgeon has an area of subspecialty interest. For example, in my case, it'd be cervical spine surgery, though we have other partners who specialize in scoliosis, for example. What that means is if you come to us, you'll get the surgeon that's really best equipped to handle the problem that brings you in.